Good morning. Once again, I welcome you all for Online Anaesthesia 2023 in a new version, sponsored by Akrula and hosted by A1 Logics and aired by Anaesthesia TV. This year, we dedicate the sessions to anesthesia consultants to update their knowledge. It is going to be once a month meeting. At first meeting of this year 2023, we have two interesting topics today. A new technique, spinal segmental anesthesia, that was added to our anesthesia armamentarium very recently. Let us look into the advantages and disadvantages of this new technique. For that, we have Dr. Naresh Paliwal to discuss on that. Since there is no data available in the textbooks, he will share his experience with us. I hope when this technique enters the textbook, he is likely to be called as the father of segmental anesthesia, as he has done a lot of research and workshops on this. The second topic is highlighting the technique which holds still the golden standard, segmental epidural. For that, we have Dr. Silamban sir, the pioneer in regional anesthesia techniques. He is my teacher also. I am having a lot of questions running in my mind. In old textbooks, there is epidural anesthesia by Bromage. Bromage used to say a resident who has performed 50 successful spinal anesthesia is eligible to do lumbar epidural. Similarly, a resident who has performed successfully 50 lumbar epidural is eligible for thoracic epidural. So the segmental spinal, is it for the beginners or experienced seniors? Is it for high-risk patients, ASA risk 3 and 4, or for elective cases, ASA risk 1 and 2? So I am eagerly waiting to listen Dr. Naresh Paliwal's lecture for these answers. To carry out today's interesting session discussions, we have senior consultant anesthesiologist Dr. Kalyana Sundara Raghavendran. Sir, he is currently associated with the multi-specialty corporate hospital in Chennai with over 40 years of experience. His area of interest is pain and ICU. Expertise in airway techniques, regional anesthesia, organ transplant, and interventional pain. He delivered many lectures in CME and conferences. On behalf of Online Anesthesia, we welcome you, sir. Over to you, sir.
Thank you, Dr. Edward Johnson. Am I audible?
Yes, sir. We are audible, sir. Please.
Okay. So today we have a good morning, everyone. We have a very interesting session today for about 2 hours. And we have two eminent speakers who are most suited to deliver the lectures allotted to them. Namely, they're going to have some sort of a debate. It's going to be a very healthy one, actually. So we have Dr. R. Silamban. And let me have the privilege of introducing him as a chief anesthetist and intensivist at VHS Chennai. He is an alumni of Madras Medical College, Chennai. He has special interest in regional anesthesia and interventional pain relief, and is recipient of KPR Young Anesthetist Award in 2005 from Kerala State Branch of ISA. He has been doing these epidurals for a very long time now, and probably he is one of the well-known authorities in the area of neuraxial like the epidurals, and he is sort of confining himself to the behind the dura. So he's not trying to breach the barrier of dura, but we have with us to sort of to cross the barrier and tell us more about spinal is Dr. Naresh Paliwal. Okay. He is an associate professor of anesthesia working at DRPD MMC at Amaravati, Andhra Pradesh. He is a well-known person now because of late his name is being quoted in most of the seminars and conferences in India as well as in international circles. And he's in a faculty in various national and state conferences plus international forums. And he has got a lot of interest in spinals. It's an age-old technique, but he has modified suitably to sort of deliver the anesthesia for even surgery which are not possible under spinals, like major abdominal procedures, thoracotomies, etc., mastectomies, etc. He has had about 28 presentations on segment spinals in the past 2 years. And he's published in many on segmental spinals international and national journals. He's conducted 2 live workshops on segmental spinals in the year 2022. And also he has published and presented on XKit, which is quite a very interesting combination and works well in many situations. And he got a Best Paper Award for DexKit presentation in Ludwig's angina. So now we are going to start off the debate. Dr. Selamban is going to tell us about epidurals first. He has been doing it since 2002, I heard. And practically, probably he has been doing it for most abdominal and maybe even thoracotomies and even neck procedures also. So he is an expert in that area, and then we are very eagerly waiting for his lecture, and also like to know about the segmental spinals. So what exactly it involves is that you're able to control the spread of anesthetics by some special techniques, special agents, adjuvants, and also areas which are not probably, if not considered before, like thoracic level. So now let me just hand over to Dr. Selamban first, who will start his lecture on segmental epidurals. Over to Dr. Selamban.
Good morning, everybody. I think I'm audible.
Yes, you are.
Good morning to Dr. Naresh Paliwal, Dr. Edward, Dr. Raghavendra, and all the other people who are in the link now. I think we'll start with segmental epidurals. We'll start with the basic of lumbar and we'll move on to the cervical epidural. Let's see how each technique is being performed and how you decide on the volume for each segment and how you go about the procedure. See, epidural anesthesia, when you call it segmental, it is something that provides blockade of the operative area and gives excellent patient comfort. General epidural anesthesia is something different. Segmental anesthesia is a little different from that. Earlier, when I was a postgraduate, when we used to give epidural anesthesia, even you let it be abdominal surgeries, we're always entering at L3, L4, L2, L3, pushing the catheter up by 10, 12 centimeters, or pushing the catheter only by 5 centimeters and giving about 20 to 22 ml of local anesthetic and doing the procedure. That is how I was doing it when I was a PG. After finishing my post-graduation joining, something said that something different must be done. So much of volume you give, hemodynamic imbalance still exists in high-risk patients. For example, a block arises from T4 till your tip of the toe. Then what is the hypotension that goes on and things like that. So that's what made me think about the segmental epidural. See, what are the advantages a segmental epidural has over GA? There's a decrease in improper blood loss. Because we give good postoperative pain relief, there's a decrease in postoperative catabolism in the patient. And suppose when you have levels of up to T4, the stress response to surgery is reduced. Because of early ambulation is possible, because of reduced postoperative pain relief we give through the epidural, there's a decrease in incidence of thromboembolism. There's no polypharmacy. So there's a decrease in PONV. Certainly, there's going to be an improvement in perioperative pulmonary function, especially in abdominal surgeries. There's avoidance of polypharmacy, airway manipulations, all those things are avoided. And it's a very reliable technique in patients who are contraindicated for general anesthesia also. So, okay, this is why I was talking about the advantages of epidural or GA. Now, epidural over advantage of segmental epidural over non-segmental epidural. There is better hemodynamic stability because only the operative areas are blocked. Other areas are not blocked. So naturally, the vasodilatation is limited to that area only. For example, you are doing a breast. The vasodilatation is limited only from C6 to T6. The abdomen is spared. So the splanchnic circulation, there is no vasodilatation and there is less fall in BP. So you get better hemodynamic stability, especially in high-risk patients and cardiac patients. Better postoperative pain relief for the simple reason that catheter is placed so high and in the exact site where the operation has taken place that with low volume itself, you get better postoperative pain relief. Toxic doses is never exceeded in prolonged surgeries or in prolonged postoperative analgesia because the volume of drug used is going to be extremely low. So naturally, there's going to be better patient comfort. There's going to be better patient movement. And it's quite comparatively very safe in the elderly and high-risk patients. So for convenience sake, or based on the type of the spines that are present in the body, let us divide it into lumbar, lower thoracic, upper thoracic, cervical, and caudal. Let us divide the epidurals into these areas because the technique of administration becomes different for each of these. So what are the principles of segmental epidural anesthesia? These are the basic points which you must know. These next two slides determine how a segmental epidural is going to be done. Any level you do, these 5-6 points which I'm going to talk now determines everything. My further talk is going to be only examples of what is being done at various levels. So this I want everybody to attach a lot of importance on what forms the basis of principles of segmental epidural. See, the important points you must notice. Whenever you call something as a segment, I repeat, whenever you call something as a segment, there must be an upper level and there must be a lower level. So suppose you're talking about a gastrectomy, the upper level should be up to T4 and the lower level should be up to T12. The lumbars are spat. So that is what we call the upper level and the lower level. Next, so any surgery you decide for this surgery, what is going to be the upper level of anesthesia required and what is going to be the lower level till which it is required. Then you decide where you place the tip of the catheter. Then you decide what is going to be the length of the catheter inside the space. Then only you decide the site of needle entry and finally the volume of the drug. So you don't decide the site of needle entry first and then try to push the catheter as much as you want. So site of needle entry is decided after the first 3 points have been decided. That is how you go about it. So methodologies decide about the area to be blocked. For example, if it is a breast, it is from C6 to T6. If it is an abdomen, it is T4 to T12 because splanchnic starts from T5. Splanchnic nerve supply to the abdomen. Then you decide where you are going to place the tip of the catheter. The tip of the catheter has to be placed in the center of the areas to be blocked or in the center of the segments which are to be blocked, taking into consideration the moment you open the epidural space and the negativity is lost, the local anesthetic spreads equally on both sides of the catheter tip, provided the patient is lying flat. Based on this, we decide where we place the tip of the catheter is exactly the center of the areas to be blocked. Then you decide the length of the catheter inside the space. The length of the catheter should not be less than 3 centimeters and should not be more than 5 centimeters. If you're going to push the catheter too much, then what happens? The catheter coils inside, it kinks, it knots, it doubles up and comes down back to your needle site, and it can also pass into the intervertebral foramen. If these things happen, then the volume of drug which you're going to give is not going to be sufficient. So the upper level may not be reached at all. Next, after we decide the length of the catheter inside, we are going to decide if less than 3 centimeters are placed, there's every possibility of a catheter exit, especially in the postoperative period. So 3 to 5 centimeters is what the length of the catheter I would suggest to place inside. Then we decide the site of needle entry. It is 2 vertebral spines or 2 segments below or above from where you want the tip. The catheter can be threaded cephaloid or the catheter can also be threaded caudally. So, for example, if you're planning 5 centimeters of the catheter to be inside, it's roughly you enter 2 segments from above or below, taking into consideration 2 centimeters of the catheter will have to be inside the space to cross 1 segment. Suppose you want 3 centimeters, then you enter from 1 segment below or 1 segment above so that you have the catheter inside for 3 centimeters. This will be better understood when you go to examples. So finally, we decide on the volume of the drug. This is an arbitrary volume which you have decided based on experience. Lumbar, being a bigger space, requires 2 ml per segment. The lower thoracic and the upper thoracic require about 1.5 ml per segment. The cervical requires anywhere between 1 to 1.25 ml per segment. In the elderly, very obese, short stature, very dehydrated abdominal patients, you'll have to decrease the volume by 0.5 to 1 ml per segment. These are my suggestions. So agents and regimen, what are you going to use? That certainly depends on what surgery you are going to proceed with. Some surgeries, extremely good relaxation is required, and some surgeries, good relaxation may not be required. Good pain relief alone may be sufficient. For example, if you take up the abdomen, the surgeon wants good relaxation. You want to do a breast. The relaxation is not as important as it is in the abdomen. Suppose you're doing a hemiarthroplasty. Initially, you may feel that relaxation is not required. But when he has to reduce after fixing the implant, if the relaxation is not good, the hip muscles are not well relaxed, the surgeon finds it very difficult to push the head back into the socket. So all these things determine what drugs you're going to use. For example, generally my personal preference would be for abdominal surgeries. My first dose is going to be 2% xylocaine with adrenaline. That certainly gives, out of my experience, better relaxation and than 0.5% sensorcaine. My second dose would be half of the first dose. My second dose would be half of the first dose. For example, my first dose is 10 ml. My second dose is going to be 5 ml. The third and subsequent doses, for about another 2 doses, you can continue with xylocaine or you can shift to bupivacaine, because once the sodium channels are open, after that, even if you give bupivacaine, the good relaxation that xylocaine helps you achieve continues. The volume for the third and subsequent doses, I use 1/3 of the first dose to a minimum of 4 to 5 ml. This is my agent and regimen choice. Fine. Now let us, after finishing all that, we are now understood how to go about a proceed on a segmental epidural. Now the segmental epidural, when it happens in lumbar, it is going to be very easy. But as you go up the spine, you will have to note the angulation of the thoracic spines and the lumbar spines and the cervical spines, which is going to make your technique very difficult. The angulation of the vertebral spine is very important in performing epidural blockade. As you can see in the lumbar side, the spines are at 90 degrees to each other. So if you just go between the two spines, you're likely to reach the epidural space. Whereas when you go to the lower thoracic, say from T7 to T11, they are at about 70 degrees angulation. So if your needle is not angulated to the angulation of the spine, you may have difficulty in reaching the epidural space. And one of the most difficult epidurals to perform is the upper thoracic epidural, right from say about T3 to T6, where they are at 30 to 40 degrees angulation, and to angulate a needle at that level, and the deepest epidural space is seen only at the upper thoracic level. So for the same patient, if you reach the lumbar at 4, only at 6.5, you lose it at the upper thoracic level because of the steep angulation involved. So basically things that are suppressed to by the needle, skin, subcutaneous tissue, basic things. Now let us just have most of us perform lumbar epidural, but just for some postgraduates who might have joined, first year postgraduates, let us have a small talk about a lumbar epidural. What surgeries can you do? Hernia raphes, all lower limb orthopedic procedures. And I think I should tell you one thing. Abdominal surgeries should not be done with lumbar epidurals. To reach such high level of anesthesia up to T4, you don't push your needle at L3, L4 and push the catheter. So I don't prefer doing abdominal surgeries with lumbar epidurals. Say example, let us take a simple basic inguinal hernia where there is not much of abdominal contents which have come out. The segments to be blocked according to the innervation as shown by the yellow coloring and also by the side diagram here is T10 to L2. So this is what we are going to. So first we have decided what is the area of anesthesia we are going to give. The upper level is T10, lower level is L2. So where do you place the catheter tip? Like I said, the catheter tip is going to be placed at the center of the segments to be blocked. That is at T12. That is where the catheter tip has to be placed. So I decide to place 5 centimeters of the catheter inside. So my site of needle entry is going to be between L2, L3. So I take about 1 centimeter to cross L2, 2 centimeters to cross L1, and 1 centimeter roughly to come to T12. This has been confirmed in many studies by application of dye and with seeing it on a C-arm. So roughly this calculation almost ends up the catheter being a T12. So we have 1 thoracic segment and 3 lumbar segments. So I'm sorry. We have 3 thoracic segments and 3 lumbar segments. So lumbar is 2 ml per segment, that's 6 ml. There is 1.5. So it totally comes to 8.5 ml is what is required. This is how the principles are applied in the inguinal hernia. So this is a schematic representation. This is very common lumbar, which even the first year postgraduates are doing. So I thought we'll skip this video and go to higher levels. At this point of time, I would also like to tell the usefulness of caudally pushing the catheter downwards. Caudally pushing the catheter downwards is a very useful aspect, especially when you're doing tibial surgeries and surgeries with the foot and diabetic foot surgeries and all those things. It's very, very useful. You thread the catheter caudally. The advantage is when you go caudally, most of the below the knee is all by the sacral segments. So you block only the sacral segments. Even if the patient's ejection fraction is 20%, 22%, you're just not bothered because most of the sympathetics are not from the sacral region. They're all higher up. So vasodilatation is going to be minimal. And the only problem would be one portion or one piece of the foot and the leg is supplied by the saphenous nerve. That can be blocked by raising a wheel with the local anesthetic at the medial side of the tubal tuberosity. So you reverse the catheter, give a wheel of local anesthetic, medial tuberosity, below knee is anesthetized without hypotension. So this is how. For example, even we want to do a dynamic hip screw fixation, which is not done nowadays. Nowadays they do PFNs now. This is how you go about it. So you decide what segments to block, T12 to L4. So catheter tip is the center at L2. So your catheter placed inside is 5 centimeters. So needle entry is 11, T11, T12. You push it inside. Push it downwards. And at 9.5 ml per hour, things are over. Invariably, if it's an old person, like I said, you reduce volume, even 6 ml would be sufficient, where minimal hypotension is achieved. Suppose in the same procedure, you want to do a tibial surgery or an ankle surgery, enter at L4, L5, push the catheter inside by 3 centimeters, give over 6 ml of volume of local anesthetic, and give a wheel of local anesthetic to block the saphenous nerve alone. That would be quite sufficient. Like I said, for tibial fixation, this is how you go about it. This video is about reversing the catheter, which is similar to a lumbar. So now coming to lower thoracic epidural anesthesia. Most abdominal surgeries, all abdominal surgeries should be done only with lower thoracic epidural anesthesia. Gastrectomies, incisional hernias, cholecystectomies, Whipple's, perforation, resection, hemolysis, everything has to be done with lower thoracic epidurals. So like I said, here again, we're applying the principle of segmental epidural at the lower thoracic region. Segments to be blocked for an abdominal procedure are from T4 to T12. So the catheter tip is going to be placed at the center, which is T8. Catheter length placed inside is going to be 5 centimeters. It is 5 centimeters. The site of needle entry will be between T10 and T11. So 1 centimeter to cross T1, T10, 2 to cross T9, and 1 to reach the middle of T8. So roughly 5 centimeters, the catheter tip comes to at 1.5 ml per segment. For this segment, you get 13.5 ml of local anesthetic. This roughly for a person who's the height of 5'8", something. Women, all those things, you can reduce volume. Certainly, once you start doing it, you'll know how much volume to reduce. Women generally with 10 ml itself, you can proceed with intra-abdominal procedures. See, I was talking about the angulation of the thoracic spines. This picture depicts the lower thoracic spine, which is roughly at 70 degrees angulation to each other. So what happens if you feel the thoracic spine over the skin and you go in between the thoracic spines, exactly in between the thoracic spines, like you do in a lumbar epidural anesthesia, as depicted by the green line, you will see that you're most likely to go and hit on the upper part of the lower spine if you go straight. So then it makes manipulation difficult to reach the epidural space. So what I would suggest is go on the lower spine, feel the lower spine, push the needle till you hit the lower spine. Once you hit the lower spine, pull it by 1 centimeter and then increase the angulation to about 70 degrees as depicted by the red line. So you will go exactly in between the center of the two spines. This is my suggestion. Now we'll have a video of a lower thoracic procedure being done. The counting of the spines is being done up to 8, where the catheter tip is going to be placed. We are planning 3 centimeters of the catheter inside. So site of needle entry is going to be T9, T10. So when you place 3 centimeters, you come there. Basically, I like to count from the sacrum or L5 S1 itself. Because when you talk of the anterior superior spine, it may not always correspond to L3, L4 or L4, L5. So always count from below when you are a beginner. So that is the space which you are going to enter the needle, and see what I depicted in the previous line diagram. The same approach, same technique I am going to use to reach the lower thoracic epidural space. Needle entry. I am trying to hit on the lower spine. See, kindly appreciate the angulation, the 70-degree angulation which I am moving. Once you hit on the lower spine, then you pull it back, and then I have turned the needle to 70 degrees. Also, while threading the catheter, try to hold the catheter very close to the needle and push it, because the pressure generated by fingers then reaches the catheter tip more easily. Hold it close to the needle. Don't hold it far away. Like I said, we want 3 centimeters of the catheter to be inside the space as per the principles of segmental epidural. You can see the angle 70-degree angulation to the skin. It is not at 90 degrees to the skin. This is at the lower thoracic level. Just trying to explain the angulation there. 5 centimeters of the needle is outside. This is a 9 centimeter needle basically. It's a Vigo 9 centimeter needle, not a regular 8 centimeter needle. See, exactly as per the by principles of segmental epidural, I place the catheter And see how I fix the catheter. I don't fix the catheter pushing it outwards. Because once you keep a sandbag, the sandbag pressure applies here and the catheter gets invariably blocked. So I try to take the catheter out in its natural direction. I just take it out in its natural direction. I roll it at that angle. Rather than fold the catheter and roll, I roll it this way. Now we are giving the drug. Checking is being done. So there is some pain at T4, but it settled after another 2 minutes. That is at T12. And see, only T12 is blocked. After that, the patient is able to move his legs. There is no motor blockade of the lower limbs. And that is a relaxation during surgery. Excellent relaxation achieved with the drug regimen I spoke before. And after the end of surgery, lasting about 2.5 hours, a huge mesenteric cyst. You can see the patient still moving his lower limb. That means his lower limbs were never, ever, see that? Anesthetized. The anesthesia remained from T4 to T12. There was an upper level and there was a lower level. Below that, it did not happen. We almost gave about 3 doses of local anesthetic top-ups. Still, the anesthesia remained at T12 itself. So, same principles with the upper thoracic epidurals. See, these epidurals have been classified only according to the angulation of the spine, nothing more. All breast surgery, simple mastectomies, modified radical mastectomies, reduction mammoplasty, CABG, beating heart, fracture pain for the upper ribs, all upper thoracic epidural, what have to be used. The same principles, just to reiterate and make sure that this principle of segmental epidural get into our minds. Segments to be blocked off from C6 to T6 because for deep axillary clearance, a level of up to C6 is absolutely essential. So the catheter tip goes to T2, T3. So catheter length to be placed inside is 4 centimeters. So placed between T4, T5. So naturally 2 to T4 and 2 to cross T3, you come to the center of T2, T3 with 4 centimeters. Needle entry will be at T4, T5, where the angulation is almost 30 to 40 degrees. And 12 ml for a healthy, robust person, but up to 9 ml is sufficient for ladies. Most MRMs can be completed with 8 to 9 ml of local anesthetic. See, this is the angulation I'm trying to say about. The same technique which I applied for lower thoracic, I'm applying for upper thoracic also. But the angulation is steep. Suppose I go between the two spines. Naturally, I'm going to go and hit against the lower border of the upper border of the lower spine. So from there, trying to force your needle through is more traumatic. So what I do is, like I said, hit the lower spine, pull the needle back by 1 centimeter, and then angulate to 30 to 40 degrees, as shown depicted by the red line. The catheter goes in, the needle goes inside very comfortably, despite the severe angulation existing at that level. So it can be a midline or a paramedian, because I'm more familiar with the midline and I use the technique which I told in a previous slide. I always prefer the midline, but there are a lot of people who also use the paramedian approach to overcome the steep angulation. Position can be sitting or lateral. I always prefer the sitting position. Very rarely have I used the lateral position. So I'm more comfortable in sitting position. So always I do it in sitting position. Another depiction of your, that is C7. The first most prominent spine is C7. Then you count all your spines up to. So blockade is going to be from C6 to T6. Or now this is going to be a simple procedure. So blockade is attempted from T1 to T6. So the catheter tip is going to be placed between T3 to T4. That is the center of the segments to be blocked. And the needle entry is going to be T5. Roughly, the tip of the scapula corresponds to C7. Roughly. Feeling for the upper spine and feeling for the lower spine. going almost on the lower spine. The upper thoracic is almost deeper when compared to the lower thoracic and lumbar. So first I go hit the spine at 90 degrees. You see the needle at 90 degrees. Now I turn the needle and bring it to that 30 to 40 degree angulation and move forward. I think the angulation is well appreciated in this angle from above. Despite being a very thin patient, the needle has already gone inside for 5 centimeters. Extremely thin patient, this patient was. This patient, if I do a lower thoracic epidural, probably by 3 centimeters, I'd be able to reach the epidural space. 4.5 centimeters is outside, 4.5 is inside, because this is a 9 centimeter needle. So the angulation now, angulation of the needle to the related to the patient's back. Same principles, first 2 slides which I said, based on the same principles, the catheter is being pulled outside to fix it at around 5 centimeters inside the space to reach between T2 and T3. Yes. See, this is another technique which I very, very rarely use. Nowadays, I don't use it very much, but initially in my early stages, I was using. I use 2 catheters for anterior AP resections, radical cystectomy, bladder removal with Roux-en-Y loop, and even for labor pain relief, I used to use 2 catheters. One for the lumbar pain, where the uterine pain, and another for the vaginal pain that happens. So what happens is I found that to be more useful because, so that is when I use even for labor pain relief, I was using that. Very limited usage. Same principles divided into 2 areas, thoracic area and the lumbar area. 1 catheter for the thoracic segment, 1 catheter for the lumbar segment or the sacral segment, depending on what procedure you're doing. Apply the same principles. For example, when you're doing a radical cystectomy, when you are going to remove the bladder, you activate the lumbar catheter. When you go above to the abdomen to trying to create a loop, you activate the thoracic catheter. This way, it could be quite useful in some cases. I've done about 2 to 3 cases in double epidural catheter, where a single surgeon was operating with one of his postgraduates. So this was found useful. The surgery lasted almost 6.5 hours. Still, the toxic doses were not used because whenever they were operating downside in the lumbar region or in the sacral region, I was using a low concentration of local anesthetic in the upper region. So when used to come there, I used to increase the concentration. That alternation was done, and that's how we did it. So the same way, lumbar, and now coming to the cervical epidural. Basically, according to me, doing a cervical epidural is as simple as doing a lumbar epidural because it is usually done at C7T1 or C6, C7. The only problem we face is that pad of fat that exists around that area in most of the people that makes palpation difficult and gives rise to lot of false spaces. When you use the loss of resistance technique, you get lot of false spaces in the cervical epidural region. So always when you come to cervical epidural, though initially I started my career doing a cervical epidural with loss of resistance technique, for the past 10 years, I shifted it to hanging drop only. Because of the high negativity in the cervical space, hanging drop is my favorite technique now. So basically for cervical disc procedures where we do a lot of pain, give a lot of steroids, I use that for thyroid surgeries. And with a combination of a mandibular nerve block and a cervical epidural, I completed 2 cases of radical neck dissection also. Probably those photos are not available in this presentation. In different presentations, they have photographs of that, where the patient is fully conscious and the neck is fully thrown open, right up to deep dissection can be done. But of course, doing a cervical epidural may be easy, but trying to maintain a cervical epidural for major procedures certainly requires a lot of experience, expertise, and skill. The same procedures is applied here. The segmental epidural technique is applied, C7T1. One thing I want to warn you here is the ligamentum flavum fails to fuse in about 30% of the people in the midline in the cervical region. So the classical feeling of your epidural needle entering the ligamentum flavum may be absent. So naturally you try to proceed further, and with the loss of a lot of false spaces which you get there, and with false positive tests with your loss of resistance technique, you usually have problems. So it can always go for a hanging drop is my suggestion. That is C71 mark there. You have to achieve full flexion of the neck to perform a cervical epidural, but invariably when there's a thyroid swelling, there is neck pain or neck disc, the full flexion is not achieved. So here we are not able to get full flexion in this patient. This is the position, head is placed on the table. This was early in my career. Nowadays, I just tell them to bend their neck and I do it. I don't place the forehead on the OT table. I think the video is not running. Just give us a second. Yes. C71. The first most prominent spine is C7. The next spine naturally is T1. The position of the patient for a cervical epidural. Full flexion is advised of the neck. The video is not moving after this. I think Dr. Edward will skip this video. It's only going on for about 5-10 seconds. After that, it is not coming. Huh? Okay. See, I think again it's come. Just one this. Check panna. Just on the kai vikar vandichu par angadhu pota kuda podum. அது வந்து நின்றுது. அது மேல நீ நடுவுல பண்ணும்போது ஓடிச்சு. Okay, we are unable to play the video, so we'll skip it. And if possible, I have another presentation. I'll just give the video clip anywhere in between if you allow me to do it, permit me somewhere. Huh? So coming to the surprising pulse, you see L3, L4 space is very rarely used in segment epidural anesthesia. It is invariably higher. Lumbar epidural should not be used for abdominal surgeries. Almost all surgeries below the level of T1 can be done under segmental epidural anesthesia as a sole anesthetic technique. And for cancer pain relief, epidural neurolysis and segmental epidural are inseparable. Even if you can't do a celiac plexus block, you can put alcohol into the epidural space based on the segmental technique. Say with 3 to 4 ml, you can achieve, given on 3 consecutive days, you can achieve pain relief for pancreatic cancers and abdominal cancers with this. And when you put these things into perspective, the most important aspect is your post-operative pain relief. So when you come to post-operative pain relief, the volume will be 0.5 ml per segment per hour of bupivacaine or ropivacaine or whatever drug you prefer to choose. So for example, if your surgical pain relief or surgical anesthesia is required for 10 segments and you're going to use around 10 to 13 ml, 5 ml per hour of epidural infusion is fully sufficient to give pain relief for abdominal surgeries. Thank you so much. Over to you, Dr. Raghavendra.
Thank you, Dr. Silamban. Can you stop sharing now? Dr. Silamban,
Yes,
you can, yeah. Okay, stop sharing. We can. Okay, wonderful talk, Dr. Silamban. A lot of valuable pearls to be learned today, and then practical points actually. And actually, you are now shown us a way, that it can be done at various levels, cervical. Many of us won't even dare to the area, but you have shown us a way how it can be done, and then a lot of practical points learned actually. Now, to take it further, Dr. Naresh Paliwal is going to cross the dural barrier and then go into the spinal subarachnoid space and tell us that segmental spinals is possible and probably it is simpler and can be achieved in a very effective manner. Okay, now we are really we are eagerly waiting to listen to your talk, Dr. Naresh Paliwal. Over to you.
Hello, am I audible?
Yes, sir, you're audible.
Just a minute, I'll start sharing my screen. Is it visible clearly?
Yeah, you can make it full. Yeah, okay, it's visible.
Okay. Good morning, everyone. At the outset, let me thank Dr. Edward Johnson and the team Online Anesthesia for providing me this opportunity. And I am very much honored to have Dr. Raghavendra as a chairperson for this session. After a wonderful talk by Dr. Silamban about the segmental epidurals, I thought it would be a nice idea to have some similarities between the two techniques and what are the pros and cons of each one to begin with. So I'll start with a few points about comparing both the techniques. What are the similarities between the two techniques? Both these techniques, segmental epidural and segmental spinal, they produce a segmental block with minimal hemodynamic changes. For both the techniques, the injection site is most important. You need to place the injection at the middle of the dermatomes that is required to block that for that particular surgery. And the concentration of the drug affects the density of block in both the techniques. Like with lower concentration of drug, it will provide mostly a differential block, mostly a sensory block. There are a few positives about the segmental spinal as compared to segmental epidural, and there are some negatives also. So firstly, the segmental spinal is very economic as compared to segmental epidural. It's quick, and there is definitive end point. Like a free flow of CSF gives a confirmation that you are in the right place. There is early onset as compared to segmental epidural with segmental spinals. And there is uniform dense block with minimal drug. Minimal drug means for segmental spinal, you just need 1 ml to spread 2 to 3 segments above and below the site of injection. And with epidurals, you need around 1.5 to 2 ml of drug per segment. That is nearly 1/8 to 1/10 of that it is required at segmental spinals. Also, the segmental spinal covers both spatial and temporal summations, while the segmental epidurals may not cover the spatial sensations always. Also, the baricity of LA apart from dose plays an important role in segmental spinals. You can always change the direction of flow using different baricity drugs in segmental spinals. And the failure rate is comparatively low, especially in cases of previous spine surgery. And if there are some spine deformities, then the chances of failure are little less with segmental spinal as compared to segmental epidurals. And obviously, as the dose required is very less, so the chances of last are minimal with segmental spinals. There's also good relaxation, and the requirement of sedation obviously is less as compared to segmental epidurals. But there are some negative points about segmental spinals. Like there is no versatility to extend the levels. Once injected, you cannot extend the levels afterwards. And also the duration of block cannot be extended. So it's not useful for post-op analgesia also. And the chances of PDPH as you're puncturing the dura are more, but that can also happen when you get accidental dural puncture during thoracic epidurals. The same thing can happen. And in my point of view, if the surgeries are major, then you can combine both the techniques together to have a better results. Now coming to my topic, segmental spinal. There is changing scenario about segmental spinals. Some 10-12 years back, let me clear it first that I am not the inventor of this technique. This is a very old technique. I just regenerated the technique with use of different drugs. And some 10-12 years back, when I started presenting this topic, my title used to be segmental spinal, is it possible? But that time there was a lot of criticism about that. And everyone raised a question about the safety concerns in segmental spinal. So I started presenting about the safety concerns. And during this COVID pandemic, when everyone wanted to avoid general anesthesia, so many people, they started trying this technique and they found that it is very useful. So it became the most trending regional anesthesia technique that time. Recently, there was an article in British Journal of Anesthesia in April 2022, I think, about defining the role of segmental spinal in 21st century. This was the article, and the conclusion they provided, I'll just read out. Despite the absence of larger trials, there is evidence from the small cohort studies and multiple case reports that TSA may be considered a safe, feasible, effective alternative anesthetic technique and may be used in patients where other anesthetic techniques pose a high risk. This was the conclusion. Now, what is segmental spinal? The term is often used synonymously with the thoracic spinal, but even a low dose is used at a higher level levels can produce a segmental effect. So the ideal definition should be blocking of the required dermatomes, essential for the proposed surgical procedure with very low dose injected near the targeted nerve roots. Here, what is important is lower the dose, more likely to produce a true segmental block. Otherwise, with higher doses, it can become your routine spinal. There are some factors which make segmental spinal feasible. At thoracic levels, the spinal cord is positioned anteriorly, leaving a significant space between the posterior dura and the spinal cord. The nerve roots are very slight and thin. The amount of CSF is also comparatively less. Both these factors make blocking of the required dermatomes very easy at thoracic levels. And also there is no difference in the onset time for isobaric and hyperbaric drugs at thoracic levels. While the isobaric drugs may take a little longer time for onset at lumbar levels. There is also natural thoracic kyphosis at T765. There are some safety concerns which are always raised when we talk about the segmental spinal. The first and foremost is, can there be neurological injury with dural puncture at high lumbar or mid to lower thoracic spaces? Can there be a ventilatory impairment with blocking of the intercostal muscles and upper abdominal muscles? Can there be bradycardia and hypotension with block extending T1 to T4 and blocking cardiocellular fibers? And last but not the least, and most important is medical legal issues, as it is still not in the standard textbooks. Now coming to the first major concern, damage to the spinal cord. This is midline MRI. The cervical enlargement fills the entire spinal canal at the level. In the thoracic segments, the spinal cord is positioned anteriorly. You can see here, leaving a significant space between the posterior dura and the spinal cord. And at the lumbar levels, the lateral space disappears almost completely. Be more clear in the next slide. Here you can see there is sufficient space to accommodate your spinal needle at this site. Imbeloni and Govia did a study on the low incidence of neurological complications after accidental dural puncture in thoracic epidurals, and they provided an anatomical explanation for this. They measured the exact distance at various sites. At T2, they found the distance to be 5.19 millimeters. At T5, it was 7.75 millimeters, and at T10, it was 5.88 millimeters. Also, Lee did study of anatomy of the thoracic canal in different positions like supine, lateral, and sitting positions. And they found that the distance was more in all positions at mid-thoracic levels, but more so in the lateral and most in the sitting positions. This is the position which most of us acquire for giving spinal anesthesia. You can see here the distance is almost 5.95 millimeters at T6 levels in sitting positions. The spinal cord sits ventral in the apex of the thoracic curve, and more so when the neck is flexed and the patient is bent forward. You can see left-hand side figure shows the distance between the anterior dura and the spinal cord. The right-hand side figure shows the distance between the posterior dura and the spinal cord. There is sufficient distance. Here again the lateral view of the MRI. Because of the angulation which is required to perform spinal at mid-thoracic levels, you may need an angle of around 45 degrees. At mid-thoracic levels, distance between posterior dura and the spinal cord is further increased. You can see here, the distance is almost 8 millimeters as compared to 4.5 millimeters at low thoracic levels. There are some additional points for in safety of segmental spinals. There are many studies about low incidence of neurological injuries during accidental dural punctures in thoracic epidurals. There are n number of studies about this. And also, many anesthesiologists use high lumbar or thoracic spaces, especially in obese and parturient patients. They use these spaces inadvertently. What that means is they are already giving this thoracic spinals unknowingly. Only in one study, only 29% of the people were found to be correctly identifying the required intervertebral space for giving spinal. Also, the intercrestial line always does not correspond with your L4 landmark. It can be as high as T12 L1, L1 L2, L2 L3. And also the level of spinal cord termination is variable, as high as T11 or as low as L3 level. You can see here, the intercrestial line can vary. It can be as high as T12 L1. The second issue, which is often raised about segmental spinal, is ventilatory impairment. Here, the main inspiratory muscle of respiration is diaphragm, which is usually unaffected. Expiration at rest is a passive process, but forceful expiration and coughing may get affected because of paralysis of anterior abdominal wall muscles. But because of the low doses of drugs used, there's a preferential selective block that preserves the coughing ability, minimal motor weakness. About the bradycardia and hypotension, the heart rate may decrease, the block extends T1 to T4, but because of the lumbosacral sparing and less venodilatation in the lower limbs, the right atrial filling is maintained, and that sustains the outflow from intrinsic chronotropic receptors, maintaining the heart rate. The negative Bembridge reflex is not initiated. Less hypotension obviously is due to the low drugs used and less sympathetic blockade. About the medical issues and litigations, now there is enough evidence for cases where it is most indicated. There are n number of studies right now, and you can always defend this when it is most indicated. And most cases of litigation are against regional anesthesia, but still the thoracic epidural is being performed day in and day out, even by the trainees. If that can be explained, then the accidental dural puncture or intentional dural puncture in thoracic epidurals can be defended. Proper explanation and consent is must, but till the time it appears in the standard textbooks, we can keep our fingers crossed. Feasibility of segmental spinal and indications. There are 4 aspects of feasibility: technical, economic, legal, and operational. Technically, it's not very difficult and different from your routine spinal. Those who are accustomed to doing thoracic epidurals, they will not find it very difficult. Even those who are doing lumbar spinals routinely, just a change of angulation and with precaution, they can do it easily. Economic, it's very, very economic as compared to other techniques. Legal, still a question mark, but can be defended with strong indications. Operational, it can be operational at any setup, right from low resource setup to high and corporate setups. About the indications, all the intra-abdominal surgeries, all, be it open, laparoscopic, major, minor, upper, lower, they all can be done under a segmental spinal. Breast and superficial thoracic surgeries, and also some awake thoracoscopic surgeries like bulectomy, thymectomy, lung volume reductions, they all can be done under segmental spinal. Even some prone and lateral position spine and musculoskeletal surgeries, they are also possible. What are the advantages of routine spinal or at times over general anesthesia? The surgeries which were thought to be out of domain of spinal anesthesia, like upper abdominal, thoracic, and breast surgeries, are possible with segmental spinal. The higher levels of the block can be achieved with just half the dose that is required at the lumbar levels. There is minimal hemodynamic fluctuations, early recovery, and voiding. These advantages are apart from the advantages which all neuroaxial techniques have over general anesthesia, like less postoperative pain, nausea, vomiting. And there are special advantages of general anesthesia in patients with the respiratory comorbidities. There is also lower incidence of post-op nausea and vomiting. There are 3 different modes of using segmental spinal. It can be a single shot spinal for short to mid duration surgeries, 90 to 120 minutes, or it can be combined with epidurals for long duration surgeries, or in a very morbid ill patients when you want to use a very low dose intrathecally for giving segmental spinal. In those cases, epidurals can be handy not only as a backup, but also by epidural volume extension technique. It can spread the low doses of drugs used intrathecally to wider segments. And it can also be useful for post-op analgesia. The third option is you can always use continuous segmental spinal anesthesia for some major surgeries or whenever you get an accidental neuropuncture during epidurals by using spinocats or interlong catheters. Drug options, either isobaric or hyperbaric drugs can be used, or a combination of iso, hypo, or hyperbarics can be used. In general, isobaric drugs are preferred for laparoscopic, thoracoscopic, breast, and intra-abdominal surgeries in morbid ill frail patients where relaxation is not an issue. Hyperbaric drugs can be a choice in some male muscular patients for open surgeries. Hypobaric drugs are not used alone. Either they are used in combination with iso or hyperbaric drugs to have a sparse cephalic or caudate spread according to situation. They are a little bit unpredictable as the concentration used is very low and the volume used is more. They are a little bit unpredictable. Sorry. Advantages of isobaric drugs: they are less sensitive to position issues, and low doses have a propensity to block preferential sensory blocks, sometimes labeled as selective anesthesia. The onset is gradual, hemodynamic stability, early ambulation and voiding. Spinal can be given directly in the operative position, like some lateral position surgeries or even prone position surgeries. You can directly give spinal in that position. That saves time and efforts. A spinal can be given before epidural. What happens when you use hyperbaric drugs? You have only one choice. You put an epidural first and then spinal. Unless otherwise, what happens with hyperbaric drugs? By the time you put an epidural, the drug gets settled to either unilaterally or caudally, according to whatever position you are using for giving epidural. But here you can use a spinal before epidural and a space higher than epidural. Disadvantages of isobaric drugs: levels of block. There is some disturbance actually. Please unmute yourself. Mute yourself.
Carry on, please.
Shilpa, unmute Naresh, sir. Shilpa. So Naresh, sir, unmute yourself.
Okay. Okay. I'm audible now.
Yeah.
Yes, sir. Yes, sir.
Okay. There are some disadvantages of isovaric drugs. The levels of block cannot be modified by change of position. You need to place the drugs at the required precise dermatomes. There is some sacral sparing with low doses at higher spaces. This can be an advantage at times, or it can be disadvantageous, especially when you want to do surgeries where pelvic manipulations is required. This can be a disadvantage, but otherwise it is a advantage to have sacral sparing with these drugs. There's longer onset time at lumbar levels. The less muscle relaxation may need to use higher doses for some male muscular patients, and they are also sensitive to temperature variations. Can have behave like hyperbaric drugs when cooled to 25 degrees, and can act like hypobaric when they are warmed at 37 degrees centigrade. Amongst the available drug options, in the isobaric drugs, levobupivacaine 0.5%, propiocaine 0.5 and 0.75%, and also chlorprocaine 1% can be used. In hyperbaric drugs, till now we had only bupivacaine 0.5% heavy, but now levobupivacaine 0.5% and propiocaine 0.75% heavy are also available, and they all can be used. There are many additives which many people are using, but the preferred ones which will not lead to post-op nausea, vomiting, and early recovery are fentanyl, dexamethasone 2 to 10 micrograms. Dexamethasone can prolong the duration in a dose-dependent manner. Ketamine has a propensity to block sensory nerves in preference. Shorten the motor block time. They will increase the duration of sensory block. Clonidine can also be used in low doses. Now, this is important. How to decide the dose and the site of injection, like Dr. Silverman said, and this also applies to segmental spinals also. Here, 1 ml of the isobaric drug spreads 2 to 3 segments above and below the site of injection. And accordingly, you can calculate the doses required for each surgery according to the dermatomes you need to block. But in general, for all abdominal surgeries, you can take it as a gross statement that 2 to 2.5 ml of the drug block segments from T2 to L5S1 with spinal at T10. You can do all intra-abdominal surgeries of short to mid duration with this much of dose. A 10 thoracic space lying in the center of the surgical field for upper abdominal surgeries. Dose of local anesthetic, additive, and the site of injection can be varied according to need. You can vary everything according to your need. For breast and superficial thoracic surgeries, spinal needs to be given at mid-thoracic levels. Preferred one is isobaric 1.2 to 1.5 ml maximum with some additives. It can provide a duration up to 60 to 90 minutes and little more, around 2 hours, if dexamethasone is used as additive with this much dose. You can always combine this with epidurals or some interfacial plain blocks for longer duration surgeries. These are the different levels required, as already mentioned by Dr. Suleiman about the breast surgeries. I'll just go through it. And epidural scoring scale for arm movements, which is used to measure the motor blockade during thoracic epidurals, can very well be used to assess the motor blockade during segmental spinals. There are 4 grades: hand grip C8, T1, wrist flexion C7, C8, elbow flexion C5, C6. Position of the patient hardly matters when you use isobaric drugs, unless you are using 2-drug technique where you need to use sitting position only. Plain levobupivacaine 0.5% is slightly hypobaric with a specific gravity of 0.990. It is on the verge of being hypobaric, and higher levels of block may be achieved if you keep the patient sitting for some time. Using 2-drug technique, I already mentioned, sitting position is mandatory. Type of the spinal needle combined with epidurals. If you are combining with epidurals, CSC kit is the safest and easiest option. You can look at the epidural space with the epidural needle, and in introduce your spinal needle that adds to the safety and efficacy of your technique. Either Quincke or pencil point needles can be used, but with pencil point needles, the chances of paresthesia are more, as the fluid exit side hole is around 1.7 millimeters from the tip. You need to enter around 2 millimeters more in the intrathecal space with pencil point needles, and the chances of paresthesia are more. These are the landmarks as already demonstrated by Dr. Silliman, but you can take the advantage of ultrasound. If you have an ultrasound machine, you can count upwards from L5S1 in the parasagittal oblique view. You can identify the 12th rib and count upwards, or identify the first rib and count downwards to locate the required spaces. There are some anatomical hurdles for thoracic spinal. The spinous process are sharply angled at T4 to T9. There's very narrow interlaminar spaces at these spaces. These are at times difficult with midline approach, so a paramedian or a paraspinous approach can be used. For paramedian approach, thoracic spinal, you need to be around 1 centimeter away from the spinous process, and then an angulation of 15 to 20 degrees medially and around 45 degrees scaphoid angulation. You hit the lamina first, and then you can change the direction bit by bit to enter the interlaminar space. And the other approach is paraspinous approach. Slide alongside the spinous process, contact the laminae, angle scaphoid to slip into the interlaminar space. I'll show a short video about this to have a better idea about this paraspinous approach. This approach is many times we are using when we think that we are using a midline approach, but we are in the paraspinous approach.
Starting more lateral using plastic media increases the possibility that proximal line pass through the contact with vertical or even with the pillars, both of which may produce. Note that this paraspinous approach is often what happens called midline approaches.
Not audible, doctor.
One side of the
Pardon? Not audible?
Audio is moving.
Video not audible.
Okay. Can I play it again?
Okay, sir.
Angle of the needle. Here the angle of needle should not be more than 5 to 10 degrees, just alongside the spinous process. Not more than half centimeters away from the spinous process. If you go more laterally, then there are chances that you may go to the opposite side, pass the epidural catheter in the pleural cavity. That also may give rise to a loss of resistance sensation. This I already told you that this is the approach. When you think that you are in the midline, often the needle slips to one side and you go via paraspinous approach. Minimum angulation is the key in this, just 5 to 10 degrees of median angulation. Ultrasound imaging of the thoracic spine is very helpful. T10 to T12 are similar to your lumbar vertebrae. T4 to T9 are steeply angled spinous processes and overlapping laminae. There is very small window in the parasagittal oblique view. And there is almost no window in the transverse view. This view is, apart from knowing if there is any scoletic abnormality or not, this view is not useful, transverse view at mid-thoracic levels. This is just to show how it looks in the parasagittal interlaminar view at the thoracic spines. The laminae look like a flat leaf-like appearance at thoracic levels against the sawtooth appearance at the lumbar levels. There is a little gap in between the laminae can be seen as an interlaminar space, but this may not always be visible in old and morbid obese patients. This can be visible in some young individuals. And you can also see the posterior complex, spinal cord, and the anterior complex. But this is the only view which is useful, parasagittal oblique interlaminar view. This is transverse view at the thoracic spine. You can see the spinous processes, laminae, and the articular processes are not visible in this view because they lie more anteriorly at thoracic levels. You can visualize the rib and the sliding pleura. As mentioned by Dr. Silamban, there is at times a gap in the ligamentum flavum at the cervical and upper thoracic levels. You can see in the right-hand side picture, there is a gap in the ligamentum flavum, which you can visualize with the ultrasound. And you may not get the classical sensation, loss of resistance sensation at this level, and you may have accidental dural puncture. So these things are to be kept in mind. There are some safety measures for successful use of segmental spinal. You need to do a thorough preoperative assessment. What are the dermatomes involved in that particular surgery? If ultrasound is available, you can do a pre-procedural scan. Identify the landmarks required for giving spinal, either by landmark technique or by help of ultrasound. Selection of the proper drug, dose, site, and mode of segmental spinal according to your patient and surgery. After giving spinal, assessment of the levels, monitoring, and proper sedation as per need. This is dermatomes, which are already seen, like for MRM, you need C7 to C5 to T7. Coming to my segmental spinal profile, more than 3,500 surgeries in last 10-12 years, initially used for only high-risk cases, but now occupies nearly 50% of my RCB profile. Till date, there have been very few partial failures, but fortunately no mishaps. Recently, we had 2 live workshops and one face-to-face interactive workshop in 2022, and there are more than 3 lined up in the next few months. I usually do a complete pre-anesthetic evaluation of the patient, emergency airway card, drugs all kept ready, venous access, minimally monitorings, no sedative pre-medications. I usually prefer lateral position for giving spinal with 27 gauge needles, drug dose, site, mode according to patient and surgery. For intra-abdominal surgeries, for very short duration surgeries like 40 to 60 minutes, or either open or lap, I prefer chlorprocaine 2.5 to 3.5 ml. Here the dose required is little bit more, as it is only 1% of the drug. And because the volume is more, you don't need to go very high up. The levels around T11, L1 puncture can give you adequate spread. For mid-duration surgeries of 60 to 120 minutes, either ISO or hyperbaric drugs with some additives. For average female patient, 2 ml plus additive, average male patient, 2.5 ml plus additives at around T10 level. This can be taken as a standard for all ASA2-3 patients. I usually combine this with either transverse abdominis plane block, rectus sheath block, or erector spinae plane block for open surgeries, or local anesthesia at the port site for laparoscopic surgeries. For breast surgeries, I prefer isobaric, either levobupivacaine, ropivacaine, 1.2 to maximum 1.5 ml, with additive like fentanyl, ketamine, or dexmet when longer duration is required at T4-5-6. Usually combined with epidurals or some interfacial plane blocks like PEC1, PEC2, serratus anterior plane block, or recently I've started combining it with full strength erector spinae plane block for post-op analgesia, and that is providing me a very good results along with segmental spinals. Now something about the 2 drug techniques. You can use combination of any 2, ISO hyper with hypo or ISO with hyper. For some abdominopelvic surgeries where you want to have a longer duration of effect at the pelvic side, you want to have involvement of the lumbosacral roots also, you can combine hyperbaric with isobaric, can give a spinal in sitting position at around T10 L1 level with 0.5 to 1 ml of hyperbaric drug, followed by 1.5 to 2 ml of isobaric drug in different syringes with some additives. It can provide you a duration around 2 to 2.5 hours, or even more if dexmet is used as additive with this much dose. You can combine hypobaric drugs also with either iso or hyperbaric drugs, as I already mentioned, to have a wider sparse cephalic or caudate spread with segments blocked. After giving spinal, patient turned desired position. Sensory block usually sets in 3 to 4 minutes. Minimal and gradual hemodynamic fluctuations, usually in initial 10 minutes. No respiratory issues even with high levels of block. Initial partial involvement of the lumbosacral roots can be seen, but which recovers within by the time your surgery is finished. There are no additional supplements. Levels are adequate. Patients can be completely mobilized in 4 to 6 hours. To sum up, it's a very useful technique with many advantages, minimal risks with due precautions. No need to panic even if the block level is found to be higher than desired. Lap surgeries may need little sedation. If available, ultrasound can be helpful for more safety. A technique is reserved for experienced clinicians with good learning curve. There are some do's and don'ts about segment spinal. I'll just quickly finish. I think I'm not running out of time. Before proceeding, know in detail about the technique. What are the various drugs that can be used? What are the different doses? What are the attitudes and the sites of injection that can be used for different procedures? You also need to know about your surgeon. If you are not used to doing or working with him, you should know how accustomed to your surgeon is doing it in especially regional anesthesia, especially the laparoscopic surgeries. How adaptable your surgeon is to the changed conditions that may provide with your neuraxial blocks. How flexible your surgeon is. If you request him to keep the initial intra-abdominal pressure to a low, around 12 to 14 to start with, initial insufflation rate to minimum, how flexible he is to listen to you, and the efficiency of surgeon, how fast your surgeon is. Accordingly, you can choose your mode of segmental spinal. And you should know about the surgery, whether it is open lap, what will be the likely duration of your surgery, what the extent of your surgery will be. Suppose if the surgeon says it will be a just internal appendicectomy, and if you palpate the abdomen, you will find that there is guarding rigidity, and it's likely to be a perforated appendix. So you need to change your side dose accordingly, in presumption that it may be a ruptured appendix and may require a longer duration. You should know about the patient also, how cooperative your patient is, whether he is willing for sole regional, what are the comorbidities of the patient, and the risk-benefit ratio of general anesthesia versus segmental spinal. Always use the position you are accustomed to in giving spinal, either sitting or lateral, unless there is a special indication for using special positions. Do a pre-procedure ultrasound scan in difficult spine cases. That can be helpful to know if there is any abnormality in the spine, squaletic abnormality, or the depth of the interlaminar space. Do use CSC kit if you are combining it with epidurals for more safety and ease of doing it. Do always use multimodal analgesia with segmental spinals. Multimodal analgesia in the form of some blocks. If you are not combining it with epidurals, then you can use some blocks. Other drugs like paracetamol, dexamethasone, diclofenac, or the drugs which will avoid the respiratory depression and post-op nausea vomiting for early recovery. Do prepare and keep ready your backup plan as always. There are some don'ts. Don't force the surgeon to do it under segmental spinal if he is not willing to do it, unless there is a strong indication in favor of segmental spinal. Don't be rough and rusty. Advance gently, millimeter by millimeter. Always take your own time. There's no rush. You should go bit by bit, removing stellate after every loss of resistance. That will add to the more safety of this technique. Don't proceed if there is slightest of paresthesia. Withdraw the needle and change the direction. Don't use high doses of local anesthesia at mid or high thoracic spaces to avoid undue respiratory and cardiovascular fluctuations. Don't unnecessarily add too many additives together. If you are not accustomed to using these additives intrathecally, use the additives you are accustomed to, and don't unnecessarily add too many additives because someone is adding, and unless it is very essential, don't use too many additives together. Don't use excessive sedation with higher levels of block unless you are planning to secure the airway with either SCDs or endotracheal tube. Because what will happen if you use excessive sedations, that may change the breathing pattern and may disturb the surgeon, especially in laparoscopic surgeries. Don't panic with early hemodynamic and respiratory issues. They are usually minimal and gradual, easily manageable. Don't hesitate to call for help or communicate in case of any doubts. I'll show some videos. This is at the lower thoracic. As I already said, lower thoracic levels are as easy as your lumbar spaces. There is not much of angulation. This is 27 gauge needle, probably for some umbilical hernia. Not much of angulation is required at lower thoracic spaces below T10. I'll just go quickly through this. This is our third-year resident giving segmental spinal. We did a pre-procedural ultrasound scan, located the space and the direction, and then asked her to give, this was an obese patient, more than 100 kgs for umbilical hernia. And she is going gently, bit by bit. The space was located, the depth was actually, we are novice in ultrasound, but depth could not be located, but just the direction of the needle, that was noted according to the probe. This is how you should go. Remove the stellate at every loss of resistance. This was umbilical hernia in a very obese patient. This is laparoscopic cholecystectomy with ETCO2 monitoring. This patient had diabetes, hypertension, old, slightly obese patient. Videos are not actually. This is MRM with combined spinal and epidural, segmental spinal and epidural. Epidural was put at T4-5 and spinal was given at T5-6. This is levels being tested. You can see the patient, how comfortable the patient is with even with such high levels of block. Just 1.2 ml of the drug. There was no sensation at C8, but her grip strength was good, indicating only a sensory block. This is MRM being done. This was a traumatic diaphragmatic hernia, probably for the first time done under combined spinal and epidural. Here we gave the spinal first at T7-8 and epidural was put at T8-9. For spinal, we used 2.5 ml of the isobaric drug and spinal was given before epidural. You see, whole of the left hemithorax was filled with intestines. This is diaphragmatic mesh repair being done. This is the patient at the end of surgery. Can completely mobile. The next day X-ray of the same patient. This was a huge obstructed umbilical hernia. It was also done under combined spinal and epidural. Epidural was put at T9-10 and spinal was given one space below. You can see is the respiration. There's a whole transverse, full length transverse incision. This was a huge variance thought to be malignant in an old morbid lady. It was compressing all the intra-abdominal structures. It was done with two drug techniques, just 0.5 ml of the hyperbaric drug initially, and then 2 ml of isobaric drugs at T12, 11, 11 in sitting position. It was a very huge cyst, so her cyst had to be ruptured. Cystectomy, omentectomy, and hysterectomy was done in this patient. This is again MRM, epidural at T4-5 and spinal at T5-6. The spinal had to be given by paramedian approach in this patient. This is at times the there are many, queries about the cautery not working properly in regional anesthesia, but if the cauteries are a bit high end and the currents are reduced, and if bipolar cautery is used, they work very nicely. There are a few changes you need to make with this technique. It's the same patient shifting herself. This was TLH with 2-drug technique. It was around 2.5 hours procedure. See the patient shifting herself. This is CA vocal cord with post-recurrent occlusion for feeding gastrostomy. Spinal was at T89, just 1.5 ml of the cleobupican and bilateral rectus sheath block. This is ruptured ectopic. Spinal was given at T1112 with 2.5 ml of chlorprocaine and 25 micrograms of fentanyl. Yeah. You can see the whole of the abdomen is filled with blood. This is a patient, she was a relative of a doctor for posted for TLH. She had atlantoaxial dislocation with bacillary invagination and diffuse disc bulges at TC56. Her C1, C2 fixation was done and she had very limited mouth opening, and she used to get vertigo during neck movements. She was very much worried about her neck movements, and when concealed her about the second spinal, she happily agreed to it, and it was done with 2-drug technique. This is ruptured liver abscess, 21 years female. The hemoglobin was just 4.9, CRP was 43.9, creatinine 1.27. You see the whole of the abdomen was filled with blood, pus. This is usually how I monitor ETCO2. I put a 12 gauge LCAT tip to the ETCO2 probe. Whenever there is the special probe for ETCO2 monitoring under spontaneous is not available, this is simple appendixectomy going on. The patient shifting herself. This is a pediatric patient, 8 years old. Laparoscopic appendicectomy. This is an obese lady for removal of polyp, cervical polyp. It was given in sitting position, T12L1. This is after 1.5 hours. The procedure went on for 40 minutes. And this is after 3.5 hours. She is completely mobile. This is a special patient. Actually, he was a patient with difficult intubation and was intubated with difficulty. And somehow he was accidentally extubated before the surgery could start. There were a lot of issues. The surgeon postponed the patient and he came back again after 3 weeks. He was actually told about this technique of segmental spinal and he agreed to it. And here you can see he is watching his own surgery, laparoscopic cholecystectomy. Consent was taken. This is male MRM, recently done with erector spinae full concentration. The patient shifting himself. He had bronchiectasis. This is 62 years female, hypertension, degenerative heart disease for MRM. She was a bit obese patient. She also was done with erector spinae plane block and segmental spinal with just 1.3 ml of the drug. Same patient at the end of surgery and after 3.5 hours, the patient moving herself. This is again 8 years perforated appendix, done last week only. You can see the abdomen filled with pus. These are my 2 publications, and thank you very much for patient listening. I hope I was clear throughout.
Oh, thank you, Dr. Naresh Paliwal. You can stop sharing the screen now.
Okay, sir.
Excellent talk and a lot of very valuable pearls learned today. And you have shown us that before the Z2 not possible and the spinals is quite possible nowadays, and they really have done a lot to popularize the technique, and they have been a guide to so many people, and then you've been helping them to learn this technique. And day by day, you can see that more and more people are using these techniques, segmental spinals. And we have learned a few things here today, points. That is, as per one admission, that we can't do it in neck level, cervical level, as well as the caudal level, whereas these are possible with epidurals now. So you're confining yourself to mostly to lumbar and the thoracic levels for spinals, is not. Then other thing is what we can notice that the situations sometimes is it possible now to do segmental spinals in all situations? Now, would you sort of almost most of the abdominal procedures nowadays, we seem that it is possible to do with spinals and epidurals as such, and barring a few contraindications. And then another thing which is gaining real popularity is the laparoscopic procedure, which also nowadays brought under the uraxial anesthesia techniques, either sole anesthetic or even a supplementation procedure. So we have lots of questions and clarifications from the audience, and we can just go over it one by one. And I just want to ask, as per Dr. Ganesh Tandulkar, the question: which technique causes better post-operative analgesia and lesser derangement of physiology? He has asked actually. Now, I just want to ask Dr. Selamban first, then maybe next Dr. Naresh Paliwal also can answer this.
Can you repeat the question, sir?
Which technique causes better post-operative analgesia and lesser derangement of physiology?
I think basically when you go for a post-operative infusion analgesic technique in epidural, the concentration is anywhere between 0.725 to 0.125%, where the hypotension is going to be minimal. Whereas when you use it at the spinal level, I am totally unaware of how totally my first time listening to a talk by Dr. Naresh Paliwal, and a lot of doubts, and I have no idea about how you go about segmental spinal, and this is the first time I'm listening to it. So really, I cannot highlight how much derangements will occur in the post-operative period. But as far as epidurals are concerned, because of the low concentration of the bupivacaine that is used, the derangement is going to be very manageable. Physiological derangement or hypertension management is going to be very manageable. Even if you, for major surgery, Whipples, which last about 4 to 6 hours, where you give continuous infusion for almost 48 hours, most of the times they don't need NORAD also for support. Just fluids are able to manage.
But Naresh Paliwal, you think that post-operative analgesia is possible with this continuous spinal anesthesia?
Yeah, there are 2-3 things which you can do with segmental spinal. If it is not a short to mid duration surgeries, you can always combine it with epidurals for post-op analgesia or some blocks, which will provide a longer duration of analgesia in these cases. The hemodynamic fluctuations are in both segmental spinal and epidural are very minimal, as the doses used in both are very minimal. But for post-op analgesia, yes, epidural can provide a longer duration, but you can always use a technique like continuous spinal or continuous segmental spinal anesthesia, even for some morbidal cases. I have done few cases. I don't have that videos, and that was not included in today's topic, so I avoided about continuous spinal anesthesia. But you can use continuous spinal anesthesia in those cases without much of hemodynamic fluctuations.
Okay, Doctor, I think you also mentioned about use of other techniques like ESP blocks and
yes,
like those can be used.
Those can be combined with segmental spinal for longer duration. Like for MRM nowadays, I am combining erectospiny plane block with full concentration of drug, like 0.5% levobupivacaine. We nowadays the isobaric drug comes in vials only, 20 ml vial. What I do is I take 1.2, 1.3 ml for my spinal, and the remaining drug I use for erector spiny plane block in a full concentration, as only unilateral is needed. So you can have the, luxury of using a full concentration, and that is providing a very good results. As you have seen, that patient was completely mobile within 3 hours. She went to bathroom and
Okay.
had all oral fluids, etc.
Now, I think there's one question that is, Suleiman mentioned about directing catheter caudally from the lumbar level.
Yes.
Now, just is it possible and to push the catheter caudally? Is it that lumbar levels? Because usually we find that it's not that difficult, not that easy to cover the sacral segments. So one person asked actually what caudal direction of the catheter from epidural space.
Sir, as we go lower down, the volume of the epidural space naturally increases. So catheterization is not going to be very difficult. Secondly, when you try to push the catheter up, if you can see the nerve roots go in the direction like this. So you'll have to go and hit against the nerve root. That is why sometimes you get paresthesia when you push the catheter up. Whereas when you push the catheter down, you go along the course of the nerve. So I don't think catheterization in the caudal side is going to be any difficult.
Okay. And then question is, what about the paramedic technique? You mentioned in your all the videos about the midline techniques only.
Yes.
Now, in thoracic level, is it not advantageous to go for paramedic, especially between the T4 to T9 like that? No?
That is what I try to explain to you with a line diagram also. Instead of going in between the two spines, if you go and hit on the lower spine and angulate the needle, it becomes very easy. Only when you go between the two spines, you land up the trouble on hitting on the bones. You go hit on the lower spine, pull the needle back by about a centimeter, then angulate your needle according to that. Suppose if it is lower thoracic, angulate at 70 to 80. If it is in the mid, if it's higher thoracic, angulate to 40. Then naturally you have no other choice but to go between the two spines. Because from once you hit the lower spine and you angulate, you naturally go between the two spines.
Okay.
And mostly, right from our learning days, most of us are very comfortable with the midline technique.
Okay. So you feel that, what about in situations, say, for instance, a patient has got some spine anomalies like kyphoscoliosis or sideway bending? Is there any special techniques used?
Basically, when you go for spinal anomalies, the use of an ultrasound can extremely be helpful to help you navigate it. Suppose if you have a kyphoscoliosis or a scoliosis patient and you try to, with help of an X-ray, pre-op X-ray, you try to navigate your needle, I think it requires a lot of experience to navigate it through. So basically, those kind of deformities, always try to take the use of the ultrasound to know where your spines are located and direct the needle accordingly. Whereas when you go for these lower procedures, the kyphoscoliosis usually starts at L2, L3 level. I go at L4, L5 or L5, L1 spinal or an epidural, where the spinal abnormalities may not be so significant.
Okay.
Actually, convex site is said to be more open for giving spinal or epidural in scoliotic spines.
Yes.
If you can feel the convexity, then you always go from the convex side.
Yeah,
and the paramedian approach is always said to be very useful for mid-thoracic because the interlaminar space at these levels is very minimal. And at times it is, you find difficult to negotiate that space, interlaminar space by midline approach. So the trick is either go paramedian or paraspinous approach, as I have shown. Just the angulation towards midline should not be more. Many times the angulation is more and then you enter to the opposite side, either intercostal space or in other structures, paravertebral spaces. So the angulation should be kept to the minimum when using paraspinous approach and even for paramedian approach, not more than 10 to 15 degrees.
Dr. Naresh, you mentioned about the use of segmental spinals in children. Is there any special considerations or any points note when you are?
No, even I have that reference for the distance between the posterior and spinal cord, even in children, is more as it is in adults. And just you may need some sedation before if the child is not cooperative.
Okay.
Otherwise,
So,
there is no special. You have to be careful.
okay. So these are the, I think probably what you're saying that even in children, you can do it with a lot of safety. The same,
Yes.
the distance to the dura
So I
to
have
the
done quite a number
spinal-
of, and even quite a number of cases in segmental spinal, laparoscopic, and even open surgeries.
Okay. Now, I just want to ask this question to both of you, Dr. Silman and Dr. Naresh Paliwal. See, somehow we feel reluctant to use spinals in a patients belonging to ASA 3, 4, 5 and all. Okay. Now, would you avoid it in such situations, or you feel still these techniques are quite feasible and quite safe? Dr. Silman, then later Dr. Naresh.
The ASA3 patients very comfortably, my option of anesthetic choice is always epidural even today for a non procedure, because the segmenting for lower limb fracture surgeries or abdominal surgeries, ASA3 I still prefer to go for epidural. But ASA4 with excessive bleeding or very severe perforation with sepsis, those kind of cases, I think already the BP is going to be quite low. And even despite use of noradrenal vasopressin to maintain a BP above 110 may be certainly difficult. So that depends on case wise, how you get the patient. What are the derangements that make you, it's a class 3 or a class 4 patient, I choose my anesthetic.
Dr. Naresh, do you think segment spinal is safer in ASA 3, 4 now?
No, actually, my point is different. I can do all the cases. We choose the drugs and the dose concentration differently. I've done at least 40, 50 ruptured ectopics under segmental spinal. Previously, I used to do it under general anesthesia only. But nowadays, I just do it under chlorprocaine or isobaric drugs, even laparoscopic. So initial just brief hypotension can be managed. Otherwise, the patients can be very well managed. And the due perforation, 8 days old. Actually, my journey to segmental spinal started with these cases only. Like patients from very tribal area, they come in very bilateral pneumonia, 8 days old perforation, 80 BP. And that's how I started doing this, and then sorted for the references and then started presenting it. So it is a little bit reverse journey. I started doing say 3, 4 cases initially in segmental spinal. You can choose the drugs. I mean, for suppose lower limb surgeries, you can choose hypobaric drugs. They do even less hemodynamic fluctuations. Recently, we have done some low ejection fraction cases for low limb surgeries.
Okay. Now, Dr. Ganesh Tendulkar, he wants to know, onco patient develops severe hypotension with the minimal doses, and he wants to know how we can avoid either epidural or endospinal hypertension aspect.
Onco patients.
Yeah. He feels
Any
that they
specific?
they-
Many onco.
prolonged
Many,
hypotension because of the poor general condition. They develop hypotension. Do you avoid spinal cyst patients, or you can still go ahead and then choose a lesser dose?
Hypotension can be managed actually, depending on the patient, what other comorbidities the patient has. Because if it is to happen, it will happen in general anesthesia also. I mean, depends on what the comorbidities the patient have. I've done many oncosurgeries under segmental spinal and epidural, combined them together for better results. And even if there is some hemodynamic changes, you can always manage it, as you can do along with your general anesthesia. The advantages here are patients post-op chances of going on ventilatory support and pneumonia are less. Post-op analgesia is better.
Any anesthetic technique that produces hypotension may not be a contraindication for the use of spinal or epidural, because we have wonderful drugs now to maintain the BP, and it is very easily manageable. Whether it be an onco case or a non-onco case, whether you do it under spinal or you do it under epidural. If the technique is supposed to produce hypotension, it can very comfortably be managed.
Unless it is an emergency surgery, you can always take a time to build them up.
Yes.
I mean, if they are in dehydration, you can correct dehydration before embarking on to your surgery.
Priyadarshini Dr. Priyadarshini, from the audience, she wants to know for upper abdominal surgeries, what is the preferred technique for post-operative analgesia? And she also wants to know the incidence of PDPH with thoracic segmental spinals.
Incidence of PDPH is very minimal, as already there is less amount of CSF at thoracic levels, and the incidence is, as compared to lumbar, is very minimal. Till date, I have not encountered a single patient actually, because I use 27 gauge needles always, but just a minor headache in 1 or 2 cases, but not exactly PDPH, but not encountered any. But also for upper abdominal surgeries, you can use rectus sheath block, or you can combine with epidural, depending on what surgery it is. Bilateral rectus sheath block, I usually combine for umbilical or epigastric hernias.
Dr. Silman and Dr. Naresh, see, sometimes we get some really obese patients. Present day, private setups now, patients come with weighing about 130, 140 kilos now. Is this epidural technique as a sole anesthetic technique still possible in such patients, or you have some reservations, or you can suggest some precautions or some how to?
It depends on for what surgery they are coming.
Obese patients, they are coming for many operations, abdominal operations, bariatrics, and whatnot. So some of them come for even cesarean sections also. So I think all this is this still possible, still safe in obese patients also, as compared to general anesthesia.
It's actually better if they can be done under regional alone. You can always combine 2-3 techniques together. If you can combine spinal with epidural, if there is accidental puncture, you can convert it to continuous spinal or continuous segmental spinal. So there are many options. Also, you have options in the drugs. You can choose the drugs accordingly, isobaric, hyperbaric, or hypobaric, according to the levels you need to achieve. If you want a higher capellic spread with head-up position, like for laparoscopic cholecystectomy, you can choose hypobaric drugs along with isobaric drugs. That what it does is it produces very sparse, only just sensory block to the higher levels. So the patient is not in very much discomfort, no hemodynamic fluctuations. If you want a dense effect at the pelvic roots, you can combine hyperbaric drugs with isobaric. So there are various options that can be put forth.
The weight of the patient is no contraindication for an epidural or for a spinal. I have done a patient of up to 145 kgs under pure epidural for an incisional hernia repair, where almost the intestinal contents are completely out of the abdomen for a very long time. But only difficulty you will face is the technique where placing the catheter in such obese patients may be difficult. But luckily,
with the help of ultrasound.
Pardon me?
Ultrasound can be helpful.
Yes.
In such
Nowadays,
cases.
with the advent of ultrasound, it is going to help you very much. So weight or obesity is no contraindication for the use of epi and spinal.
Okay. One more problem is now in laparoscopic operations with a steep head-on positions and abdominal. They put peritoneal cavity filled with carbon dioxide now. You think it's still possible to do these cases with epidurals or under spinal? Dr. Silman and Naresh, both of you, I think, can give opinion.
So as far as I'm concerned, say about 8, 10, 12 years back, I started doing laparoscopy surgeries under pure epidural. Certainly, I was able to complete most of my surgeries, say about 60 to 65% of surgeries comfortably. The other 35%, I did have problems, especially when the pneumoperitoneum was induced and the air was pressing on the diaphragm. Patient did feel discomfort. And next thing is the steep head-down position some surgeons ask. And there I always felt the quality of the surgeon was more important than anything else. Some surgeons I finish lap chole in 20-30 minutes.
Uh-huh.
So that time, that way, when you have a pneumoperitoneum lasting for a shorter period of time, some patient discomfort are used to manage with sedation. But some people even do it for 1.5 hours. That time is certainly in about 20 to 30% of patients, I had problems with the pneumoperitoneum pressing on the diaphragm.
Yes, that's what I told in my do's and don'ts, that know your surgeon, whether he is accustomed to doing it in regional anesthesia or not,
Yes.
first thing. Because if he is not accustomed to doing it in regionals, he will complain for anything. The second thing is how adaptable your surgeon is. I mean, if you ask him to keep the initial intra-abdominal pressure to minimum, what I asked to my surgeons when doing under regionals, I asked them to keep it around 12 or maximum 14 initially. And the initial flow rate, I asked them to keep minimum around 2 to 4 liters per minute. So that sudden inflation may at times stretch the peritoneum and can cause discomfort. That I have seen even under general anesthesia. The patients can get severe bradycardia with such flow rates. But these are a few things which I asked my surgeons, and also prefer isobaric drugs for laparoscopic surgeries, because with steep hit down tilts, if you use hyperbaric drugs, they can spread downwards. And also the isobaric drugs, they have a propensity for pure selective, I mean, mostly a differential block, mostly a sensory blocks. So patients don't feel any, I mean, discomfort, because the muscles are usually spared. The respiration is good. So done quite number of these surgeries, laparoscopic surgeries. The levels need to be adequate for these surgeries, about T2 at least.
Okay, good. The thing is, now what about the one thing everybody wants to know is the legal implications. I think you did touch upon that actually, So epidural, I think probably people have accepted it because you don't really go near the dura. I mean, you don't puncture dura and don't go near the spinal cord. But always there's a theoretical concern and possibility that the cord may get damaged. So this is what is inhibiting people who are sort of advising against the spinals. I think the legal implications, can it be overcome in a due course of time, or is it a real serious problem nowadays, which is preventing people to go into this aspect of it's quite a very useful technique, and then is feasible and can be done for a lot of situations, a lot of procedures. So what do you think about it, Dr. Naresh?
I just wanted to ask, how will you defend if you get accidental dural puncture during thoracic epidurals? I mean, is it defendable? I mean, there you are telling you are doing a epidural and you accidentally punctured the dura. But in segmental spinals, till the time it appears, you can select the cases properly. In the cases where it is most indicated, you can always justify. I think there are many publications about this, where general anesthesia, even the recent article in British Journal of Anesthesia, that can be taken as a reference point. There also they have mentioned that can be useful for certain situations where you think that the general anesthesia can be risky. So it can be defended with strong indications. But for routine surgeries, I'm not sure. I mean, you have to be confident that you will do it nicely, and then only you can do it.
I have a question for Dr. Naresh Paliwal. Just out of.
Yes, sir.
So, when we do a segmental epidural, say, for example, the level is from T4 to T12, the regression of anesthesia is from both ends.
Yeah, it is from both ends.
It's from both ends. Whereas when you do a conventional spinal, the regression is always from above below.
Above below.
For example,
that is because most of the time what you use is
a complete my question, sir. For example, you do a lumbar spinal for a bottom surgery. At L2, L3, 11, give only 0.8 to 1 ml. So what happens is the block starts coming, roughly the block is from T12 to S3, S4. And it starts regressing from above below only. Does it regress from below upwards also is my question.
No, it is the difference of the drug you are using. Actually,
you're using hyperbaric bupivacaine. Then what happens, sir?
Hyperbaric, it regresses from above downwards.
Above downwards.
Yes. With
Okay.
isobaric, it is just like your epidurals. It
Okay,
regresses
okay.
from both ends.
I got it.
Okay, one last question before we wind up. I think almost near the end of the program.
One more question for Dr. Naresh, sir. Sir, can you elaborate your technique of high thoracic spinals in cases of very much anticipated difficult intubation?
With patients with difficult intubations.
Yes, high thoracic, because in case there's a small error and it becomes a total
Yes,
spinal,
yes.
you'll have to ventilate
Yes.
for a very long time.
With difficult intubations,
What is your experience with that and
giving-
what's the exposure to such cases?
giving regional will not solve the issue of difficult intubation. You need to be prepared with everything about difficult intubation before embarking onto the spinal or any other anesthesia, even for lumbar spinal also. You need to take all the precautions. You need to be prepared with everything which may be required for that difficult intubation.
Yes, you're right, sir. I do accept. My question is different. Say, for example, for a femur fracture, I'm giving 2 cc of hyperbaric bupivacaine at L34. Chances that I may lose the airway is very minimal. Then
Yes, yes.
when I give it at the high level of T10 or T9. So what would be your advice to me is my question.
For lower limb surgeries, you don't need to go higher up. You can always do it with lumbar spinals.
No, I'm talking about the higher surgeries when you have a difficult intubation. What is your experience?
I do it with all precautions. I mean, I have all the gadgets ready with the difficult intubation if it is required. No fiber optic, no. But Tascope, I have that intubating bougie.
May I add 3 points? May I
Yes,
add
yes.
3 points for this question? In
Yes,
recent
yes, you can.
difficult intubation guidelines, they advise regional anesthesia even in the presence of difficult intubation. You can go for regional anesthesia with definite precautions should be taken for the difficult airway. So that's the answer for this question.
Yes, that is what I am saying. You should always take all the precautions that may be needed in case there is any emergency. You should always be prepared for that, and then only you can embark.
Sir, there is
two
questions.
The question is very simple. The question is, you don't have a fiber optic bronchoscope with you.
No, the fiber optic bronchoscope is not needed. I have a Tascope.
Assuming it has become a total spinal. Suppose you go for a GA in that procedure, you are going to ventilate for about 3 to 5 minutes because anticipated difficult intubation, you're going to give succinylcholine. Here, if it becomes a total spinal, you may have to ventilate for 1 hour. So what is your advice to me is my question. See, every case, we keep every precautions for a difficult intubation or a loss in airway for every patient. These specifically anticipated patients, where you go for a scrolling intubation, where you are in trouble of not intubating, only for 5, and you don't have a fiber optic bronchoscope, you ventilate only for 5 to 7 minutes before the patient comes out. Whereas when you give a high thoracic spinal, the duration of loss of respiration is going to be more than 45 minutes or even an hour. So what is your experience? What is your advice?
I'll tell you just one experience. Yesterday only, I was called by a physician, case of severe pancreatitis, who went on in failure, and he was not able to intubate that patient. She was very obese patient, and she was semi-conscious and not opening her mouth. Actually, she was keeping her mouth closed. It was difficult to intubate. Tried opening, scoline was not available, and she was ventilated for some time. And then at the last resort, what I did was took a CVP line guide wire, did a retrograde intubation in that patient. So there are many things which you need to be conversant with. Like I can do blind nasal, I can do blind intubation after giving scoline, or you can use SGDs, supraglottic devices in such cases for time being. Or we have Tascope, which is also very helpful. We have Booging ventilators, we have cricothyroid atomic kit. So there are many equipments available, even if you don't have fiber optic bronchoscope or this thing available.
I'm just going to give an opinion on this. My own opinion only. See, I think whenever we have a difficult airway situation anticipated for elective operation, which is likely to be a very severe procedure and maybe with a lot of fluid shifts and all, I feel it's safer to go ahead with securing the airway first, maybe awake, FOB guided or whatever technique, and then only venture into other. I mean, give GA for case. This is my opinion actually. Regional, yes, you can use it. You can use it if at all. Peripheral operations now, which are not likely to cause much of a problem, and anticipate problem is not much. But still, whatever you said applies. See, like keep everything ready in case of difficult. But when you anticipate difficulty and this operation of a major nature, I think better to go for a secure the airway first. What I feel. Okay.
Yes, that's what I'm saying. It depends on what procedure you are going on for. If you are going for a lower limb surgery where the chances of patient requiring intubation are very minimal. So in that case, you can just prepare for the everything ready and then go for regionals. If the procedure is like such that you may need, there are a high risk of intubation. In such cases, you need to secure the airway first. I mean, major procedure or major fluid shift, as you said. In those cases, you can choose the technique accordingly. But when the chances are minimal that the patient going in for total spinal with very minimal drug are very minimal, or patient getting some anaphylactic reactions, or patient going in for shock, the chances are minimal. In those cases, these are rare happenings, can happen anytime. In those cases, you can prepare your difficult airway cart ready, everything ready, and go in for regionals.
Ramita sir, there is 2 questions from Bala Bhaskar to Naresh Pariwal. The first question is, in case of patients with low cardiac output, can we take a segmental spinal? The second question is, how to manage shoulder pain in segmental spinal? This is from our senior member.
I'll take the second question first. The shoulder pain is not encountered if adequate levels with segmental spinal are achieved. And a few things which I already told, that intra-abdominal pressure and flow rate, initial flow rate kept to minimum. These things, if they are taken care of, then usually there is no shoulder tip pain. And if it is there, you can use the sedation like Dexket, that can be used. And the second question about the low ejection fraction cases, I have done many cases with like one case of PPCM, peripartum cardiomyopathy, which I did, was having an ejection fraction around 26 only. And there what I did was, I did with just 1 ml of the isobaric drug and combined with epidural. Just 2 ml of epidural top-up was needed along with 1 ml of isobaric drug, and the patient was okay. Next day she was moving. The epidural was used for post-op analgesia also. So you can combine these techniques together. You can combine 2-drug technique also for such cases.
Thank you. Sir, please go.
Dr. Naresh and Dr. Silamban, after giving epidural or spinal as a sole anesthetic technique, how do you take care of patient comfort intra-op?
Like what kind of comfort? You're talking about sedation?
Yes, because they are going to be awake and then major operations are going on, and then how do you sort of take an intraoperative comfort?
So sedation is required. We sedate the patient either midazolam or dexmedetomidine or combination of both.
Okay.
Yes, intrathecal adjuvants we use generally, and very little sedation is required after that.
See, when you go
Plus, what I do is I use some blocks additionally.
So when you go on a total continuous epidural, like staging laparotomies, which may last up to 4 to 5 hours, good sedation is certainly required for the surgery to proceed. Because when you talk about a continuous epidural technique for surgeries, or Whipples or cystectomies, it may last 4 to 7 hours also sometimes. Staging laparotomies take such a long time. So pure epidurals, if you have to do it under them, good sedation is a must. I use a combination.
Recently we have started doing it under continuous spinal with new catheters available, interlong 25 gauge catheters. that provides very dense and effective blocks with very minimal drugs for long duration surgeries in very morbid ill cases.
Okay. Thank you so much, Dr. Naresh and Dr. Silamban.
Thank you, sir.
It was a very wonderful session, and we have learned a lot of new points, and that we can extend this this technique to so many operations now. And previously thought to be not feasible, not possible, is not possible after listening to the lecture. I'm sure that the audience would have benefited, and who were watching would have sort of learned a lot of new things. And of course, we have to be careful, and then we have to sort of do a few things, the lumbar level first, then go into the thoracic level, and expertise is gained. And as indicated by Dr. Naresh Paliwal, these techniques are quite safe and possible. And theatre concerns aside, and legal implications aside, they are actually opening up more opportunities now, giving us more choice actually as far as techniques are concerned. And we had to use our discretion and then choose the techniques in a very judicious manner. Okay. Thank you so much. I think it was a wonderful session. Okay. We'll wind up with this.
Thank you, sir. Thank you.
Thank you very much for providing me this opportunity. Thank you, Raghavendra sir. Thank you, Dr. Silamban, Dr. Edward. I hope it was, fruitful presentation.
Thank you, everybody. Thank you, Dr. Naresh, sir.
Thank you, sir. Thank you,
All
Raghavendra.
the conferences.
Okay.
Yes, sir.
Thank you, Raghavendra sir, for your excellent conclusion. I thank the speakers, Dr. Silamban, for highlighting the very old golden technique of epidural, which stands for the time. And also I thank Naresh Paliwal for updating that new technique in our armamentarium of anesthesia. And he's excellently concluded as the do's and don'ts, which has to be carried out in our practice. Thank you, the speakers, Dr. Silamban and Dr. Naresh Paliwal, for this wonderful session. It was a very good received session, and many senior members like Balabhaskar sir and Professor Kannan has attended. I am very much pleased to have them in our forum. And thank you, one and all, for the viewers. We will meet next week with a more interesting topic. Thank you. Thank you. Thank you, Ananda.
Thank you very much.
Thank you,
Any
everybody.
questions
Thank you.
remaining, we can answer on the forum.
Okay, sir. We will carry out the further discussion in our online anesthesia forum. Thank you.
Okay, thank you very much.
Thank you.
Thank the Akrula and the A1 Logics. Thank you.
Thank
and
you.
Anesthesia TV. Thank you. Silpa, we can wind up.